Welcome back, students. Now, in this video, let's continue with the sex-cord stromal tumors. We have already completed epithelial ovarian tumors and germ cell tumors. Now, sex-cord stromal tumors, they are mainly divided into sex-cord tumors and stromal tumors. Please concentrate here. The sex-cord tumors, they are further divided into estrogen secreting tumors where the tumor cells are producing estrogen, and one such example is granulosa cell tumor. Androgen secreting tumors where the tumor types are producing the androgens, which includes Serotonin Leydig cell tumor and Hyla cell tumors. So what we can know here, that the sex-cord tumors are divided into two different types based on the type of hormone it is producing, the androgen secreting and estrogen secreting. Granulosa cell tumor is an example of estrogen secreting tumor, and Serotonin Leydig cell tumor is an example of androgen secreting tumor. Now if you are talking about stromal tumors, it includes Fibroma, Thecoma and Fibrothecoma. Now let's discuss in detail. If I am talking about the granulosa cell tumors, we all know that the granulosa cells, they are associated with the estrogen production. So just think basically, in a granulosa cell tumor, if there is too much amount of estrogen production, so all the complications which a female is going to get, they are because of this hyperestrogenic state. What does I mean by? We know that estrogens are helping for endometrial proliferation. So if there is too much amount of these estrogens, that cause too much amount of endometrial proliferation. If there is too much amount of endometrium, that can cause too much amount of menses. So there will be menorrhagia associated. Okay, something like that. Okay, so this is the whole concept. If there is too much amount of estrogen, all the symptoms are because of this hyperestrogenism. Okay, so why this granulosa cell tumor? So before going in detail about the granulosa cell tumor, know that this granulosa cell tumor is the most common, it's the most common sex-cord stromal malignancy. After that, why this granulosa cell tumor? Very important MCQ. It's because of mutation in a gene known as FOXL2 gene mutation. Okay, well and good. Now it is associated with the secretion of estrogen mainly, and but can also progesterone. Okay, well and good. Now see, this granulosa cell tumor, it can be seen in an adult or it can be seen in a children. If it is present in adult subtype, what are the symptoms that a female is going to have? Very simple. I have already said, too much amount of estrogens, too much amount of endometrial proliferation, and that too much amount of endometrial proliferation is associated with menstrual irregularities like menorrhagia, abnormal uterine bleeding, breast tenderness. Why there is breast tenderness? We know that estrogens are acting on the breast tissue for the proliferation. If there is too much amount of this endometrium, that can cause breast tenderness. Okay. It can be associated with the postmenopausal bleeding and endometrial hyperplasia and endometrial cancer. See, estrogens helping in endometrial proliferation. Good. If there is too much amount of estrogens, that can cause endometrial hyperproliferation. So that is endometrial hyperplasia. We all know that endometrial hyperplasia is a pre-malignant condition for endometrial cancer. So if there is too much amount of estrogens, and this too much amount of estrogens can cause endometrial hyperplasia, that any time can convert into endometrial cancer. Okay, so a female with a granulosa cell tumor, it is at a risk of developing the endometrial cancer. So what we should do, as she is having this high risk, we have to do the endometrial sampling. So this is a screening we are doing. So endometrial sampling should be done for all females with the granulosa cell tumor. Why? Because they are at a risk of getting this endometrial cancer. Now let's talk about the juvenile subtype. So what is this juvenile subtype? The same granulosa cell tumor, if it's happening in a small child, it's a juvenile subtype. So how they are going to present? It's a granulosa cell tumor. It's producing too much amount of estrogens. We all know that too much amount of estrogens can cause breast development. So there will be precocious puberty. A female is going to present with a precocious puberty, especially if she is a child. She is going to present with the precocious puberty. Okay, see here, the small child, like she is having abnormal breast development for her age. For her age, there shouldn't be that much amount of breast. So in a juvenile subtype, she is going to present with a precocious puberty. And on histopathology, you can see these called excimer bodies. See, what are these called excimer bodies? See, called excimer bodies are nothing but the granulosa cells. See, these granulosa cells, they are arranged around a eosinophilic secretion. See, there is a central eosinophilic secretion around which the granulosa cells are concentrically arranged. So, granulosa cells arranged in clusters surrounding a central cavity of eosinophilic secretions, and these granulosa cells or these tumor cells is also having a coffee bean nuclei. So, important point. We have already seen that a coffee bean nuclei is also associated with the Brenners. There we have already seen, and I am also saying that coffee bean nuclei is also mainly associated with the granulosa cell tumors called excimer bodies, where there is arrangement of these tumor cells around a eosinophilic secretion looking like a primordial follicle. Okay, so these are the called excimer bodies which are seen on the histopathology. Now, what are the tumor markers? Important. So, the granulosa cell tumor marker is inhibin and anti-Mullerian hormone. So, these are all the important points about the granulosa cell tumor, which is the most common sex-cord stromal malignancy. After this, let's talk about the androgen secreting tumors, which are Serotonin leading cell tumors. What are the important points to keep in mind? We all know that it's an androgen secreting tumor. So if it's androgen secreting tumor in a female, what it will do? Too much amount of androgens will cause hirsutism, and so much amount of androgens cause a more drastic changes, more severe changes, like even virilization. So let's see. Serotonin leading cell tumors, usually they are benign in nature and rare tumors. They secrete androgens, we have already seen that, but rarely they can secrete estrogens, but that's very rare. Now, the age group which is affected is 30 to 40 years of age. On histopathology, you can see a seminiferous like tubules with Rinke crystals. Okay, see in this histopathological slide, you can see all these crystals. See, these crystals are especially seen in the leading cell tumors. Okay, these are the Rinke crystals. Okay, which are made up of 3-beta hydroxysteroid dehydrogenase. That and all not needed. Important point is on histopathology, Rinke crystals are seen with Serotonin leading cell tumors. They produce androgens. Okay, so these tumors produce androgens, and because of this hyperandrogenic state, there can be hirsutism, which is mild. Okay, so what you are going to have in hirsutism? That's male pattern baldness can be there, abnormal facial hair can be there, a male pattern baldness, and even you can have acne. Okay, this is okay, but more severe changes, more permanent changes. See, this virilization, it's a permanent change. Okay, it's a permanent change. What and all you are going to have in the virilization? So these are the permanent changes, which include the clitoral enlargement, a breast atrophy, and a deepening of the voice. So these and all are the more severe changes which are seen with the virilization. Now, important point you have to keep in mind is, see, when we are discussing PCOS, there we have studied that PCOS is the most common cause of hirsutism. Okay, PCOS, there is no doubt, PCOS, polycystic ovarian syndrome, is the most common cause of hirsutism. Okay, why? Because there is too much amount of androgens, and that androgens can cause this kind of facial hair, acne, that and all. Okay, well and good. But remember, hirsutism because of PCOS, it is adult onset and insidious in onset. This is the important point. Insidious in onset, which means it's very much gradual. It's just not like a very much rapid. It's not rapid onset hirsutism. It's gradually, slowly takes a lot of time to have this kind of hirsutism features. So, hirsutism in PCOS, it's a gradual insidious onset. But if a female, if she is having a ovarian tumor or adrenal tumor, these tumors are pouring lots and lots of androgens, and this so much amount of androgens at a time can cause rapid onset hirsutism. So important point to be noted here is rapid onset hirsutism is seen with the ovarian or adrenal tumors. Insidious onset, adult onset is seen with the PCOS, and PCOS, I am again repeating, it's the most common cause of hirsutism. Rinkus crystals, Serotonin ovarian cell tumor. Okay, now let's continue with the fibroma. Now here in fibroma, we have already discussed, when we are discussing about the Brenner's tumor, we have discussed something like Brenner's is associated with the pseudomix syndrome. There I have said mix syndrome is associated with fibroma. Okay, so let's see. Usually these fibromas, they are benign in nature and mostly they are unilateral tumors. See here in this female, you can see that only one ovary is getting affected. Unilateral tumors and benign in nature. Now on histopathology, you can see a fibroblasts. Okay, so fibroma, fibroblast. There is so much amount of fibroblast which can be seen in this tumor. Okay, so well and good. Now it is associated with the mix syndrome. What does I mean by? See, mix syndrome is nothing but a condition of a pleural effusion and ascites due to a benign tumor, and that too fibroma of the ovary. See in this female, you can see there is this ascites, okay, this yellow color fluid which is getting accumulated in the abdomen, that's the ascites, and even here in her lung you can see the pleural effusion. So because of a fibroma, if a female is developing pleural effusion and ascites, then you should call it as a mixed syndrome, and the mixed syndrome is because of this fibroma. There is no doubt. Okay, so these are the important points you have to keep in mind regarding fibroma ovary. Now let's continue with the Krokenberg tumor. See, what exactly is this Krokenberg tumor? Please concentrate, guys. Krokenberg tumor is an example of a metastatic tumor. What does I mean by? See, Krokenberg tumor is not a primary ovarian tumor. It's not a primary ovarian cancer. See, this cancer have originated somewhere in the body, maybe in the GIT, maybe in the breast. From these places, the tumor cells got metastasized to the ovary, and there in the ovary, they are getting proliferated. So, I can clearly say that Krokenberg tumor is an example of a secondary ovarian tumor or secondary ovarian cancers. Okay. Now, so what is the most common site from which this Krokenberg tumor is getting metastasized? It's the gastric cancer. Okay, so gastric cancer is the most common cause. Or gastric cancer will metastasize to the ovaries, and there it can proliferate as a Krokenberg tumor. So metastatic spread is most commonly from the gastric mucosa followed by a breast. Also remember that this cancer is spreading from the stomach. Okay, from the stomach it's coming to the ovaries via retrograde lymphatics. Okay, still it's debated, we are not very much sure, but this is the best answer you can keep. So retrograde lymphatics are the route for the spread of this Krokenberg tumor from the stomach to the ovaries. Often these tumors are bilateral in nature. So you can see both the ovaries are affected. Mostly it's bilateral. Okay, often bilateral. But the important point here to be noted is these tumors, they are symmetrical mostly, and the ovaries retain their shape, and the capsule is intact. Okay, there is no rupture of the capsule, and ovaries retain their shape. So this is a very, very important point. The tumor is mostly waxy in nature. Okay, waxy consistency, waxy nature, and important points are they are symmetrical. Ovaries retain their shape, and the capsule around the ovary is intact. It's not ruptured, and the most common site for the metastasis is gastric cancer. Now, if you do the biopsy and if you see on histopathology, you can see the tumor cells. Which are mainly filled with the vacuole which contains mucin. Okay, so a tumor cell have a vacuole which contains mucin, and this vacuole is kicking the nucleus to the periphery. Okay, the nucleus is going to come to the periphery, so it just looks like a ring. So signet ring cells, okay, on histopathology you can see signet ring cells. Okay, so signet ring cells are seen with the Krokenberg tumor. You can see here. Okay, these and all are the signet ring cells. After seeing the Krokenberg tumor, let's continue with the surgical staging. Guys, we have discussed the epithelial cell tumors, we have seen the germ cell tumors, six-cord stromal tumors, metastatic tumors. Okay, well and good. All different types of ovarian tumors we have completed. Now, what is this surgical staging? The staging of the ovarian cancer is done not clinically but via surgically. What does I mean by? If a female have some symptoms, now she came to us, now we have diagnosed that she is having this ovarian cancer. First what we will do is the surgery. After doing surgery, we are going to remove her uterus and ovaries. That's a total abdominal hysterectomy and bilateral salpingo-oophorectomy. First surgery. After doing surgery, we are going to send these contents, okay, what and all we have removed, we are going to send it to the path lab. The pathologist, he is going to examine and he will be giving you the staging. So first surgery followed by staging. So we are not doing the surgery based on the staging. First we will do the surgery, later we will do the staging. So this is the surgical staging. Now a female came, we have started the surgery. What we are going to do? We are going to give a midline incision. Okay, we are going to do the laparotomy. We are going to cut open the abdomen, midline incision. Now, if you see there is ascites, okay, if you find that there is this ascites, what we are going to do? We are going to collect this ascitic fluid. We are going to send it to the path lab for cytology, just for to know whether this ovarian tumor, if it is spilling some of the cells, microscopic cells, into this ascitic fluid, so that there might be microscopic deposit. So to know whether there is a microscopic metastasis or whether this tumor cell is getting getting entered into this ascitic fluid, what we are going to do is collect this ascitic fluid, send it for the cytology. That's what we are going to do. If there is no ascites, what we have to do is just create an environment which just looks like ascites. Means you have to do a peritoneal washing. Okay, so all these peritoneal pouches, you just do a saline washing and collect this fluid. You have to do, okay, you have to put the saline fluid and you have to wash these peritoneal pouches, and you have to collect the saline and send it for the cytology, just to know whether there is any microscopic small cells which are present already outside the ovary. Why? Because there is no gross appearance, you just want to know whether there is any microscopic spread or not. So for that, after midline incision, if there is ascitic fluid, collect that ascitic fluid, or if there is no ascites, you just wash them and collect this fluid and send for the cytology. Okay, well and good. Now assess the pelvic and abdominal organs. What does I mean by? You just look at the gross morphology of the ovaries, how they have affected, is there is any peritoneum affected, is there is any small metastasis happening onto the liver, or there is any these deposits which are present onto the diaphragm or omentum. So what you are doing is assessing all the pelvic organs. You are just checking what and all the organs have affected. Is the tumor just lying to the ovaries, or is there is any gross deposits? Okay, now that you are going to do. After that, what you will be doing is you will be performing total abdominal hysterectomy with bilateral salpingo-oophorectomy. Important point. So this is what we are doing for the ovarian cancer. If someone asks you what is the treatment that we'll be doing for the ovarian cancer, that's total abdominal hysterectomy along with the bilateral salpingo-oophorectomy. Now after that, you have to do the infracolic omentectomy. Why you just want to do the infracolic omentectomy? Because see, there is no gross pathology. It's just looking like the only ovaries are affected. Only ovaries are affected. Now, you don't know whether the tumor cells have already been metastasized to the organs, pelvic organs. So what you will do is, you have to collect the samples. See, you cannot do something like collecting all the samples from omentum, liver, or like in peritoneum. You can't collect many samples. So what you have to do is at least take a sample which is going to be most commonly affected, that is omentum. So you have to do infracolic omentectomy to know whether there is any micrometastasis or not, and also do a peritoneal biopsy. These and all we are doing. See, this infracolic omentectomy, peritoneal biopsy, ascitic wash, okay, ascitic fluid collection for cytology, all this we are doing to know whether there is any presence of this micrometastasis happened or not. But just think logically, if you can see a very big lump of tumor on the capsule of liver, which means you can grossly see them. In that conditions, you no need to do this ascitic fluid collection and sending for cytology. Why? Because you can grossly see that the tumor have already spread. So in that conditions, there is no need of all these things. If you can see a tumor deposit onto the diaphragm, if you can see a big tumor lump which is attached to the peritoneum, in that conditions, all these are not necessary. But in that cases where you cannot see nothing, only ovaries are affected, you just want to know, you just want to confirm that there is no micrometastasis. So to confirm that, we are doing this ascitic fluid collection. We are doing this infracolic omentectomy to know whether there is this metastasis happened to omentum or not. Why? Because that omentum is the most commonly going to be affected. Now, you can also do the peritoneal biopsy. Along with that, you have to do pelvic and para-aortic lymph node sampling to know whether there is this lymphatic spread or not. Like, that lymph node involvement is there or not. So, we are going to do all this step, and later we are going to know the staging of the ovarian cancer. So what is the staging of the ovarian cancer, guys? It is a surgical staging. Important point. Okay. Now, see, in advanced stages, optimal debulking should be done. What does I mean by? See, optimal debulking, it means that you are removing the tumor as much as you can. For example, see, in this staging, have I showed you, have I discussed that you have to remove a certain part of a liver? Have I discussed something like that? No, I haven't discussed. Why I am discussing right now? See, in advanced stages, if I am talking about ovarian cancer stage 4, for example, or ovarian cancer stage 3, it's the advanced stage of the cancer. Now, it's advanced stage, which means that already the abdominal organs are getting affected. The liver is getting affected, for example. See, if the liver capsule is affected, now I have to remove that part of tumor which is affecting the liver along with some normal amount of liver tissue. What I'm trying to put into your mind, see here, in surgical staging I haven't mentioned that, but if you can grossly see them, if you can grossly see this kind of deposits onto the peritoneum, onto the diaphragm, or onto the liver, what you have to do is you have to try to remove them. Okay, so optimal debulking means removing the tumor as much as you can. Okay, you are removing all the tumor which you can see. So that's optimal debulking. It is done in advanced stages. Yes, you have to do. If you can see the tumor, you have to remove it. Okay, but what if you are seeing a tumor which is present on the diaphragm? It's not able to, you cannot simply remove that tumor. You can't simply create a puncture in the diaphragm. So in that cases, why? Because it's a muscle, it helps in the respiration. You can't simply put a hole into the diaphragm. So in that cases, what you can do is a suboptimal debulking. So what you have to do ideally you have to do the debulking. But in that cases where you can't do debulking, in that cases you can do suboptimal debulking. Okay, so that's the important point you have to keep in mind. All these are the important points about the surgical staging. Now, after seeing this surgical staging, let's talk about the stages of the ovarian cancer. Now, it's very simple. In stage 1, the tumor is localized to ovaries, means ovaries are affected in stage 1. In stage 2, there is this pelvic extension, means the tumor is extending to pelvic organs. Okay, well and good. In stage 3, the abdomen is getting affected. First ovaries, next pelvis, next abdomen is getting affected, and stage 4, it's the distant metastasis. Simple. Ovaries, pelvic extension, abdominal extension, distant metastasis. Now let's see one by one in detail. Now if I am talking about stage 1, Stage 1 was further divided into 1A, 1B and 1C. What is 1A? Simple, only one ovary is affected. Tumor is limited to one ovary and that too the capsule is intact. 1B, both the ovaries are affected, capsule is intact. 1C, the capsule is ruptured. 1A, only one ovary. 1B, both the ovaries, but in 1A and 1B, the capsule is intact. 1C, the capsule have ruptured. See, it can be 1A, it can be 1B. What does I mean by 1C? Whether there is involvement of one ovary or two ovaries, doesn't matter. The capsule is ruptured. If once the capsule is ruptured, you are going to 1C. Now here 1C, when the capsule is ruptured. If it is 1C1, it is surgical spill. What does I mean by? You are performing the surgery and accidentally the capsule is ruptured and all the contents of this tumor, all the contents of its cyst just spill into the pelvic cavity or abdominal cavity. Now this is surgical spill. Okay. Now if the capsule have ruptured before surgery, pre-operative rupture, then it is 1C2, or in 1C2, either you have to see the tumor growth on the surface, the capsule, you can see the surface growth. It is 1C2. 1C3 means the malignant cells in the ascites or peritoneal washings is coming positive. See, we have collected that ascitic fluid, right? Now, if this ascitic fluid, if it's coming like, if the cytology is coming positive for the malignant cells, it is 1C3. So, this is all about the stage 1. Stage 1, 1A, 1 ovary, 1B, 2 ovaries, 1C, capsule rupture, doesn't matter whether 1 ovary is affected or 2 ovaries are affected. 1C, capsule ruptured. If it's 1C1, surgical spill. 1C2, pre-operative spilling, pre-operative rupture. 1C3, it's a malignant ascites. Okay. Now, in stage 2, there is this pelvic extension. What does I mean by pelvic extension? Like it's spreading to the pelvis. In 2A, this 2 was divided into 2A and 2B. In 2A, the tumor is spreading to fallopian tubes or uterus. Okay, the tumor, if it's spreading to fallopian tubes and uterus, then it is 2A. In 2B, there is this extension of tumor to the pelvic organs like bladder and rectum. 2A, fallopian tubes and uterus. 2B, bladder and rectum are getting affected. So, stage 2 completed. In stage 3, we all know that abdominal organs are getting affected. So, in stage 3, which abdominal organs are getting affected? Let's see. Now, this stage 3 was very, very important and a little bit more complicated. 3 was divided into 3A, 3B and 3C. 3A, 3B, 3C. 3A was further divided into 3A1 and 3A2. Okay, well and good. Now, what's happening in 3A1? If the retroperitoneal lymph nodes are getting affected, once the lymph nodes are getting affected, you are coming into stage 3. Which lymph nodes? Retroperitoneal lymph nodes. So, involvement of retroperitoneal lymph nodes is making the stage 3. In 3A1, retroperitoneal lymph nodes are affected. Again, this 3A1 was further divided into 3A11, 3A12. In 3A11, this retroperitoneal lymph node metastasis or the retroperitoneal lymph nodes, they are less than 10 mm in size. If the size is more than 10 mm, it becomes 3A12. Okay, 3A12. It's more than 10 mm. So, retroperitoneal lymph node involvement, stage 3A1. Now, in stage 3A2, there is a microscopic extrapelvic involvement. What does that mean by? See, microscopic cancer, you have taken the biopsies from peritoneum, you have taken the biopsies from omentum, you have taken the biopsies from some part of liver. Now, what it's coming is, there is a microscopic cancer present. See, you can't see grossly. Okay, you can't see grossly, but there is a microscopic cells. These microscopic tumor cells are invading, have already metastasized into the peritoneum or into the omentum. Now, in 3B, 3A2 it's microscopic. In 3B and 3C, 3B and 3C, please concentrate. There is a macroscopic involvement. There is, you can see grossly. Grossly, you can see that there is this tumor deposits. Okay, these tumor deposits are present. Grossly, you can see with the naked eye. Where they are present? They are present on the capsule of liver and spleen. Okay, on the capsule of liver and spleen, you can see these macroscopic deposits. So, what's the difference between 3B and 3C? The difference is, grossly you can see, but if it's small in size, okay, less than 2 centimeters in size, if this tumor is less than 2 centimeters in size, and that too it's present on the spleen or liver capsule, not the parenchyma, it's just the superficial involvement of the liver and spleen. Now it is 3B. If it's big in size, big enough, more than 2 centimeters, it is 3C. Okay, well and good. Now let's talk about the stage 4. Stage 4 is the distant metastasis, where there is a pleural effusion with a positive cytology. Very, very important. Pleural effusion. Which stage of ovarian cancer? Stage 4. Pleural effusion with the malignant cells in the, that effusion, that fluid, it's stage 4 of the ovarian cancer, that too stage 4A. Now, so what is stage 4B? See, stage 4B, it's very important that if the superficial capsule, if there is superficial involvement of the liver, there is only superficial or the capsular involvement of the liver, it is 3B and 3C, we have discussed. But once if the tumor is getting inside the liver, okay, once if the tumor is getting metastasized into the parenchyma of the liver or spleen, then it is stage 4B, where you can see the parenchymal metastasis of spleen and liver, and also a very, very important MCQ, inguinal lymph nodes are getting affected. Involvement of retroperitoneal lymph nodes, 3A1. Stage 4 is involvement of inguinal lymph nodes, MCQ. Very much important. So this is all about the staging of ovarian cancer. Okay, well and good. See, already we have done the treatment. Already treatment is done. Why? Because we have already removed ovaries and uterus. Okay, ovaries and uterus is already removed. If you can see something grossly for stage 3 and 4, we have already done the debulking. So even before the staging, we have done the treatment. So now what we can do after staging, based on staging, and based on staging and based on the type of tumor, whether it's a epithelial ovarian tumor, germ cell tumor, a 6-cord stromal tumor, based on the type of tumor, what we can do is post-operative chemotherapy we can do. See what we are doing here? Chemotherapy, but not the radiotherapy. Why? Because these ovarian tumors, please note that the ovarian tumors are radio resistant, except dysgerminoma. There also we have discussed. Dysgerminoma is the only ovarian tumor, only germ cell ovarian tumor which is highly radio sensitive. But rest of the ovarian tumors, they are mostly radio resistant. So we are not doing the radiotherapy here, but what we are doing here is a chemotherapy. Now, what type of chemotherapy? It depends on the type of ovarian tumor. If it is an epithelial cell tumor, what we are going to do is we are going to give them paclitaxel along with the platin group of drugs. Okay, paclitaxel along with the platin group of drugs, which includes the carboplatin or cisplatin. Okay, so paclitaxel, carboplatin or cisplatin, IV or intraperitoneally, okay, either via IV route or intraperitoneal, paclitaxel and cisplatin for almost 6 cycles we have to give, and all the stages should be given. See, all the stages of epithelial ovarian cancer should be given except stage 1A and 1B. Except stage 1A and 1B of epithelial ovarian cancer. See, the staging is same for all the ovarian cancers. Now, except for stage 1A and 1B of epithelial ovarian cancers, you can give this post-operative chemotherapy for rest of all the stages. Okay, so what we are giving? Paclitaxel along with the platin group of drugs, which includes cisplatin, carboplatin. Other than this, you can also give cyclophosphamide, adriamycin and a platin group of drugs. But the best treatment can be paclitaxel with the platinum group of drugs. This is something very much best. Okay, this should be the best answer. Now, for a germ cell tumor, what we can give? For a germ cell tumor, we can give BEP regime. Okay, so what is this BEP regime? BEP regime B includes the bleomycin, etoposide and cisplatin. Okay, BEP, B-E-P, bleomycin, etoposide and P for platin, that's a cisplatin. So these three drugs can be given for a germ cell tumor like a post-operatively. Now this should be given to all the stages of the germ cell tumors except, okay, it can be given to all the germ cell tumors except dysgerminoma stage 1. If it is dysgerminoma, and that too if it's in stage 1, no need to give this BEP regime. And immature teratoma, okay, immature cystic teratoma, we have discussed that immature cystic teratoma is the most common germ cell malignancy. Okay, it's the most common germ cell malignancy, we have already discussed that. Now for immature teratoma stage 1 grade 1 and dysgerminoma stage 1, except for these, for all the other germ cell tumors and for all the other stages, you can give this BEP regime. There is no doubt, very much important. Now for a 6-card stromal tumor, there is no need of this post-operative chemotherapy. Okay, usually surgery is enough, but in stage 3 and 4, you can give a BEP regime. Okay, important. So this is all about the post-operative chemotherapy. Simple. If it is epithelial cell tumor, paclitaxel, platins. That's it. IV or intraperitoneal. All stages can be given except stage 1A and 1B. If it is a germ cell tumor, important point is BEP regime, bleomycin, etoposide and platins, cisplatin. All stages can be given except dysgerminoma stage 1 and immature cystic teratoma stage 1 grade 1. 6-card tumors no need, but if it's stage 3 or stage 4, 6-card stromal malignancy, then you can go with the BEP regime. Okay, so these are the important points about the post-operative chemotherapy. Now, we have completed the ovarian cancer. Now, I just want to take a few more minutes and let's discuss about the non-neoplastic cysts of the ovary. In the name itself, it's very clear. They are the non-neoplastic cysts. What does I mean by? See, what we are going to discuss right now, something like a follicular cyst, corpus luteal cyst, theca luteal cyst. See, they are simple fluid-filled cavities. They will come and they will resolve on their own, even without any treatment. Most of the time they will resolve by themselves. So they are functional ovarian cysts. They are called as functional ovarian cysts. Why? Because they will simply resolve on their own. And examples of these cysts are follicular cyst. What does I mean by? See, there is an ovarian follicle. Usually a mature ovarian follicle, it should rupture and there should be ovulation, and that ova should be like a met with a sperm, or it can simply disintegrate and via menstruation it should come. What does I mean by? There is this follicle, it's growing, it should rupture and produce the ovum. Now what if it's not getting ruptured, it's simply growing and accumulating the fluid? That causes follicular cyst. It's a follicle, but it's forming a fluid-filled cavity. It's a follicular cyst. Same like that, corpus luteum. It should usually undergo disintegration. What if it's not getting disintegrated, it's forming a fluid-filled cavity? So that's a corpus luteal cyst. So what I'm trying to say is, these are not that dangerous and they can easily resolve on their own. Okay. So follicular cyst is the most common cyst of ovary. Corpus luteal cyst is the cyst which undergoes rupture most commonly. Important MCQ, what is the ovarian cyst which undergoes rupture most commonly? It's the corpus luteal cyst. Now theca luteal cyst, usually seen in that conditions where there is increased beta HCG. So the conditions where there is increased beta HCG, something like in the twin pregnancy or something like in the molar pregnancy. So in these conditions, you can expect a theca luteal cyst. So important points are this. Note, cyst. When we are going to call it as a follicle, and what is the demarcation point to call it as a follicle and to call it as a cyst? If a follicle size, if it's getting more than 3 centimeters, then onwards you should call it as a cyst. Okay, and these are functional ovarian cysts and they will resolve on their own. So examples are follicular cyst, most common, thecal luteal cyst, which is associated with the increased beta HCG, and corpus luteal cyst, which is the most common to rupture. Now, I have repeated this point. No need of any treatment. But what if this cyst it's undergoing rupture, or this cyst it's undergoing torsion and creating a lot of pain? What if this cyst is increasing in size so much? In that condition, there are certain conditions where you have to surgically operate this cyst. So let's see what is the management of a non-neoplastic ovarian cyst. First of all, you don't need to do anything. Why? Because they resolve on their own. But if the cyst size is increasing more than 7 centimeters in a reproductive age woman, if the cyst size is increasing more than 7 centimeters, do the surgery. If there is this cyst in a postmenopausal age, say postmenopausal age, they are at a risk of developing this ovarian cancer. So if there is this cyst in her ovaries, and that too this female is a postmenopausal woman, now you should suspect that there is ovarian cancer might be developing in this female. So what you have to do? Go with the markers. So check the CA125 levels in a postmenopausal woman. If the levels are more than 35 international units, go with the surgery. So this is all about the postmenopausal woman. What if there is a cyst? There is a cyst in a prepubertal age. We have already seen that 10 to 30 years age group, the most common ovarian cancer is going to be germ cell tumors. Okay, germ cell tumors. So if there is a cyst in prepubertal age, something like in a 10 years, this might be a dermoid cyst, or this might be a dysgerminoma, or this might be a yolk sac tumor, choriocarcinoma, embryonal cancer. So just think about the germ cell tumors and go with the markers which are suggesting the germ cell tumors. Here you are not going to check the CA125 levels. See, in a prepubertal age, this is the golden point. In a prepubertal age, CA125 levels are not significant. Even in the reproductive age, CA125 levels are not significant. Why? Because the CA125 levels are going to be raised in many benign conditions, something like a fibroid of the uterus. Okay, uterine fibroids are associated. Okay, let me show you here. Uterine fibroids are associated with increased CA125 levels, and endometriosis is associated with increased CA125 levels, or uterine TB is associated with CA125 levels. So in a prepubertal age group, CA125 levels are not significant. In a prepubertal age group, you have to think about a germ cell cancer. So for the germ cell cancer, what are the tumor markers? LDH, alpha fetoprotein, beta HCG. So in a prepubertal age, you have to check for LDH levels, alpha fetoprotein levels, and HCG levels, and if they are high, you are going to do the surgery accordingly. Okay, so this is what you are going to do. Now, symptomatic cyst during pregnancy. What if there is this cyst during the pregnancy, and that too this cyst is symptomatic? Symptomatic in the sense, maybe there is too much amount of pain because of the rupture of the cyst, or maybe due to the torsion of the cyst. So in these conditions, you have to immediately do the surgery. Okay, regardless of the gestational age, regardless, it doesn't matter in which trimester she is, whether she is in first trimester, second trimester, or third trimester, it doesn't matter. If she is having symptoms because of this cyst, do the surgery. Now what if it's a asymptomatic cyst? Asymptomatic cyst, and that too it's a small cyst. If it is asymptomatic during pregnancy, there is no need of any treatment. No need of any treatment. If it is symptomatic, regardless of the gestational age, do the surgery, perform surgery, and remove the cyst. Okay. Now, what if, this is a special condition, what if there is this asymptomatic cyst, but it's a large cyst, asymptomatic large cyst greater than 10 centimeters in size? Now in this condition, what you should do? Now in the conditions like this, you have to depend on the trimester. This is a large cyst, it's growing, Now, if you have found it in first trimester, you have found that this is in the first trimester. Now what you have to do, don't do anything. Why? Because first trimester is very much crucial because of all this organogenesis happening. So first trimester, don't do anything, just do wait and watch. Okay, if you have found this large asymptomatic cyst in the first trimester, don't do anything, wait and watch. Then what we have to do, remove this large cyst. Okay, remove this large cyst in the second trimester. Okay, plan the surgery in the second trimester. Okay, well and good. What if you have seen this large asymptomatic cyst in the third trimester? You have found this in the third trimester. What you have to do? Now here, if you are planning, this is already third trimester. If you are planning to go for a cesarean section, now while doing the cesarean section, like after the delivery of the baby, even remove this cyst. If you are planning for the cesarean section, remove the cyst also at the time of cesarean section. Okay, so remove it during delivery if LSCS is planned. If you have planned this, remove it along with the delivery. What if she is going through the normal vaginal delivery? After delivery, post delivery, 6 weeks, means post delivery, you have to wait for 6 weeks and you have to remove the cyst. It's very simple. If you have found the large symptomatic cyst in the third trimester, either you can remove it while doing C-section or plan it 6 weeks after the delivery. Okay, remove the cyst after 6 weeks. So this is all about the management of non-neoplastic ovarian cysts. So with this, we have totally completed the topic of ovarian cancer. Okay guys, I hope this video is helpful to you. Thank you.